Hello, and welcome to this educational workshop entitled The March of Innovation in Prostate Cancer Advancing Veteran Care with an Expanding and Personalized Treatment Arsenal. I'm Dr. Matthew Rettig, Chief of Hematology Oncology at the VA Greater Los Angeles Healthcare System, and I'm also the Medical Director of the Prostate Cancer Program at the David School of Medicine at UCLA in Los Angeles. I'm pleased to be joined by my colleague, Dr. Alicia Morgans, a genitourinary medical oncologist from the Dana-Farber Cancer Institute in Boston.
Thank you so much, Matt. It's really a pleasure to be here. And I'm excited to talk about therapeutic advances for patients with advanced prostate cancer and talk about our experiences with real world use in team based care.
Great. We'll cover what these advances mean for our patients, especially in the veteran population, and share our perspectives for integrating their use in the clinic. I want to thank Peer Review and NAVREF, the National Association of Veterans Research and Education Foundations, for providing this session, and Bayer and Novartis for providing the educational grants for this workshop. As a reminder, please respond to polls when they pop up on your screen and enter your questions for us in the chat window. The slides and practice aids can be accessed in the activity menu now and downloaded after this session. So let's get started. Today, we'll learn that clinical evidence really supports modern and emerging therapeutics for advanced prostate cancer. Collaborative treatment plans and the personalized use of newer therapies for prostate cancer support improved outcomes in unique patient populations and inform shared decision making. Patient education and effective AE management are supported by team based strategies. So, here are the key gaps and unmet needs. So, first of all, prostate cancer is the most commonly diagnosed cancer in the VA and the second leading cause of cancer related mortality. It has a higher incidence amongst veterans and is classified as a presumptive service related condition. There is potential hesitancy amongst veterans to undergo biomarker testing, and veterans with prostate cancer face unique challenges, including past exposure to service connected toxins such as Agent Orange, complex health status, multiple comorbidities, and potential disparities in care. So collaboration really is the key to close the gaps. Multidisciplinary teams involved in prostate cancer care, including urologists, radiation oncologists, med-oncs, together with the VA's National Virtual Tumor Board, support access to expert guidance for complex patient cases. So here is the first question. Which of the following represents a challenge to your treatment decision making for patients with advanced prostate cancer, especially veterans at your practice or institution? Select all that apply. One, understanding available emerging intensified options. Two, navigating VA community provider collaboration and logistics. Three, providing patient education for available therapies. Four, AE management and quality of life considerations. Or five, awareness of clinical trial opportunities. There's really no right answer, and we'll really discuss many of these issues in today's lecture. So, the VA is really a national leader in, of course, veteran centered care. The VA is the nation's largest integrated healthcare system. There are about 9 million veterans who get care in the VA, and each and every day, the VA provides comprehensive, high quality, patient centered healthcare services to millions of veterans across the country. The VA Health Network includes over 1,200 healthcare facilities, including major hospitals, clinics, nursing homes, other specialized care centers that are spread across all 50 states and territories. Importantly, the VA has a unique public private partnership with academic centers, training nearly 70% of the nation's doctors. And VA healthcare providers, including research, are typically dual appointed personnel at their academic affiliate. And therefore, the VA really represents one of the largest public private partnership models across the US government. Okay, so here is the current status of prostate cancer in the veteran population. So, as I mentioned, over 9 million veterans receive health care from the VA, and prostate cancer is the most common diagnosis amongst our veterans, representing about 30% of all new cancer diagnoses in the VA. The burden of prostate cancer is substantial, and well over 200,000 survivors of prostate cancer are treated in the VA, with about 15,000 new diagnoses every year. Importantly, prostate cancer is a presumptive Agent Orange related condition. So, clinical trials across the VA are available for cancers, including prostate cancer. And NAVREF, the national nonprofit that oversees the local nonprofits, has advanced clinical trial participation in ways that don't require a veteran to travel hundreds of miles to a VA. The patient could at their labs or imaging locally, meet with a study coordinator virtually, and still be fully enrolled in a clinical trial. NAVREP is really helping drive this transformation, connecting sponsors with VA sites capable of supporting these models. So NAVREP brings together industry, VA medical centers, and VA affiliated research nonprofits to increase the number of high quality clinical trials, speed up the launch and execution of the trials, and improve the key components of clinical trial execution, including recruiting, enrollment, and retention of study patients. In 2018, the VA Precision Oncology Program for cancer of the prostate was established as a strategic partnership between the VA and the Prostate Cancer Foundation, the largest foundation to support prostate cancer research in the world. And this has led to an expansion of genetic testing and counseling, prostate cancer clinical trials, and FDA approved drugs targeted to specific cancer mutations. On that map, you can see a lot of different Captain America shields and red dots, which represent some, but not all, of the major medical centers that are participating in the PopCap network. So I think the VA is really especially powerful to execute clinical research. Investigators can identify patients for clinical trials, monitor their outcomes, and analyze real world data across a large and, importantly, quite diverse population. Veteran patients can be followed from diagnosis through survivorship, and their longitudinal view helps providers understand not only which treatments work, but also for whom and why. While some veterans get their care through the VA, others receive a portion of their treatment in the community. And this can lead to fragmentation of care. It can make it hard for veterans to know what clinical trials are available or for clinicians to provide continuity of care. And this can impact and involve community practices in both practical and powerful ways. I can tell you that anecdotally, in my UCLA practice, I have patients who have difficulty affording care, and I find out that they're veterans that can receive care at the VA. They come over there, they get their drugs, and they ultimately prefer to stay at the VA for various reasons above and beyond just cost issues. So, this is really an important and effective way to identify veterans who might qualify for VA programs or research studies. And veterans cannot be connected to VA clinical trials, benefits of service, or services if you don't ask in the first place. So, continuing along this line, it's really important to coordinate care between the community and VA sites and enable a hybrid participation model, which in turn makes research more available and flexible. Community oncologists have an important role in whether a veteran learns about a clinical trial opportunity in the first place, and veterans, importantly, can refer to community care for clinical trials, and the VA will cover the cost of standard of care management. That's really important. So you can send a veteran to any academic center that's doing a clinical trial, and the clinical trial could be executed at that center, and the VA will cover all of the standard of care components of that clinical trial. So, designing studies that allow some procedures or monitoring to happen in the community clinics allow for more veterans that can be reached. So, we've had a lot of therapeutic advances over the past few years, really widening the treatment options that we can offer our patients. Dr. Morgans, can you walk us through some of these data?
I am very happy to. So let's get started. And I think one of the most important and potentially confusing things until you think about it and consider its implications is that there has been a restructuring, a renaming of our terminology, the classifications that we give to different states of prostate cancer. And the purpose of this was really to ensure that we were trying to be thoughtful um, around our patients' feelings around use of the word the castration and trying to eliminate that from our terminology. Now, instead of hormone sensitive, we use this terminology APMN or APMS. As you can see in the explanations below that figure, APMS and APMN are androgen pathway modulation sensitive or androgen pathway modulation naive if they've never had any treatment delivered. And so this is, again, meant to be a little bit more accurate. For patients who are treated with a hormone depriving therapy, they would then develop or could develop non metastatic APMR instead. So, this is a little bit different. This was what we used to call non metastatic castration resistant disease. And in this new nomenclature, this is non metastatic androgen pathway modulation resistant. Again, it's replacing that castration resistant terminology. As patients progress down the line, you can see that these statuses turn into metastatic APMN or APMS. They can also come in with de novo metastatic APMN, so metastatic androgen pathway modulation naive disease. Or they could develop metastatic APMR, androgen pathway modulator resistant disease. And ultimately, everyone, if they continue for long enough with this disease that has not been cured and it continues to be treated, they will develop APMR, which is our old metastatic castration resistant prostate cancer, or androgen pathway modulator resistant disease. And that is specified by the therapy to which patients have been exposed. I think it will be more descriptive, more accurate, more precise, and more responsive to patients, but will take some getting used to until all of us have this APMN, APMS, and APMR rolling off our tongues. In general, I think we, in addition to nomenclature, have found that there has been so much changing in this world of prostate cancer treatment. And there has been an incredible evolution of care for our APMN or APMS patients, or patients who used to have what we called metastatic hormone sensitive prostate cancer. Back in 2014, we found that delivering docetaxel chemotherapy per the charted regimen would prolong the time to progression and actually prolong survival for patients. And since that time, we've had additional studies telling us that if we add various androgen receptor pathway inhibitors, we can further uh, in prolong survival and delay time to complications and progression of disease, including things like abiraterone, apalutamide, enzalutamide, and darolutamide, with or without docetaxel chemotherapy. And we'll run through some of these. So, as I mentioned, we have level 1 evidence that we can improve survival for patients with APMN or S or metastatic hormone sensitive disease. This has been shown repeatedly across all of these trials to improve survival. And here we have additional information from piece 1 that is information on our triplet regimens where we have docetaxel chemotherapy added in and we add our APR androgen receptor pathway inhibitor on top of that. And we find that when we compare ADT plus docetaxel plus abiraterone versus ADT and docetaxel, we can improve survival in high volume disease, and not as clear perhaps in low volume disease in the piece 1 trial, which is illustrated on this slide, but certainly in high volume disease when we build on that ADT docetaxel chemohormonal backbone. RSNs was a trial that included patients receiving ADT and docetaxel with or without darolutamide in this metastatic hormone sensitive space. And we found that adding darolutamide very clearly improved survival in this all comers population, as we can see here. And this led to the FDA approval of darolutamide in that triplet regimen of ADT, docetaxel, and darolutamide. We also saw the breakdown by volume status, which I just talked about in the piece one abiraterone and docetaxel study. And here we can see a very clear improvement in terms of the overall survival for patients who have high volume disease when darolutamide is added to an ADT and docetaxel backbone versus ADT and docetaxel. And in low volume disease, we could see that the hazard ratio still appears to benefit those patients who are receiving darolutamide in addition to an ADT and docetaxel backbone, but that is not statistically significant here, perhaps because of numbers, and perhaps because this is a population that in general does actually better. And this is some of the thought that led to the consideration of perhaps doing a study like ARANOTE, which is looking at ADT and darolutamide as a doublet therapy. And here's the ARANOTE schema. As we can see on the left, this included patients with metastatic hormone-sensitive prostate cancer who came into the study and were treated with ADT and placebo or ADT and darolutamide. Again, to try to understand in an ADT and ARPI doublet situation, can we do better with darolutamide versus ADT and placebo alone? And here we can see on the right-hand side, we clearly see an advantage in terms of radiographic progression-free survival by adding darolutamide to that ADT backbone versus ADT alone. And this led to the approval of darolutamide as a doublet combination in 2025. RSEC is a study that actually just reported very recently looking at the ADT and darolutamide doublet in a US-based population because ARANOTE was all ex-US. And this study used a really interesting design. It was a single arm study of ADT and darolutamide with a control arm of ADT alone from the CHARTED trial, which again is a trial that was reported out in 2014. These patients all received ADT alone. In the US population, this was really important because it would not be an ethical thing to randomize patients to receive ADT alone when we just reviewed that study after study suggests that adding an AR pathway inhibitor to ADT is going to improve survival in this metastatic hormone sensitive population. And so all patients in this trial, this prospective trial, received ADT and darolutamide, and they compared to historical control arm CHARTED. Importantly also, though, they used this a technique called propensity score matching to make the patient populations in these prospective study arm, the darolutamide and ADT, ARASEC arm, match that historical control arm from CHARTED, which was relatively older. So it was portions of the CHARTED population that ended up being included, maybe not the entire control arm, to match as closely as possible the patient characteristics and allow a reasonable non-randomized comparison. As we can see on the bottom left, the ADT darolutamide combination clearly improves progression-free survival versus the ADT alone in this doublet with a hazard ratio of 0.29. So this is really confirmatory and reassuring. Also importantly, the ARASEC study looks at overall survival and found that ADT darolutamide improved overall survival in this comparison versus the ADT alone arm. Again, also important because ARANOTE, the prospective ex-US study, did not use overall survival as a primary endpoint. So I think one of the things that we think about in clinical practice is not just adding on an ARPI to ADT, which of course is the new standard of care, but also whether we're doing enough by doing that doublet combination. And what we can see is that if we can get our patients' PSA to get down to a very low level, less than 0.2 in some of these analyses, we can actually improve our outcomes as compared to patients who do not get to that less than 0.2. And we can see that those patients in Titan who received apalutamide, in Arches in the bottom left who received enzalutamide, in ARANOTE, those patients who received darolutamide, all had an improvement in these disease control outcomes when they got to that PSA of less than 0.2 versus when they did not. And we could see that even with the triplet combination in ARASENS down below, again, those patients who were achieving that combination. So we wonder, and there are future studies to figure out, if we don't get to that less than 0.2, should we add something else at that time and adapt our strategy to meet that endpoint? Uh, I should also say that we do have quality of life data from AirNote, which is the ADT darolutamide combination, that interestingly showed that if we get to that very low PSA response, we can have a longer time to PSA progression and a longer time to deterioration of quality of life than if we don't get to a low PSA, if our PSA is greater than zero point 0.2. So we know overall, darolutamide added to ADT improved health-related quality of life for the overall population, and that was particularly enhanced in patients who had that extreme response in terms of PSA. Additionally, we know some additional information about cognitive change associated with these AR pathway inhibitors. There are differences in the structure for different ARPIs, which of course makes them different drugs. And darolutamide and enzalutamide specifically differ in their structure, as you can see in this image here, but also in the ability of these molecules to penetrate the blood-brain barrier and cross into the central nervous system, with darolutamide having low levels of CNS penetration and enzalutamide having more so. In order to assess whether there might be differences in terms of effects on cognitive function, given these differences in CNS penetration, the ARICOG trial investigated that in patients who had metastatic castration resistant prostate cancer, non metastatic CRPC, or metastatic hormone sensitive prostate cancer, and included patients to be randomized to either darolutamide with low CNS penetration or enzalutamide with higher CNS penetration, and followed them with a primary endpoint of understanding and measuring, comparing cognitive change as assessed on a computer based cognitive test between treatment arms, primary endpoint at 24 weeks. What we can see here is there is also the opportunity for patients to cross over from one arm to the other. If they experienced a complication on their treatment, they could, if they preferred, cross to the other treatment arm. The computer-based cognitive test modules that were used in this study were all validated for remote completion, were completed by the patients at home. These are not clinically based tests. They do not diagnose dementia, but are used in behavioral health testing to understand if there might be cognitive functional change in people. They measured the domains listed here: executive function, visual memory, working memory, and attention, comparing them between groups. What we found at 24 weeks is that there was a greater change in the maximally changed cognitive domain. So the domain or cognitive test that was changed the most in each treatment arm for patients who were treated with enzalutamide, this changed more, declined more than those patients treated with darolutamide. You can see that the maximally changed cognitive domain was more commonly the PALFAM domain for patients treated with darolutamide, which includes some visual memory changes and executive function, and was more commonly the SWM module from CANTAD for enzalutamide treated patients, which is uh, executive function and working memory. But in any event, there was a significantly greater change in multiple modules. In 4 out of 5 modules, greater a decline with enzalutamide and with darolutamide between treatment arms. So let's look at a case and think this through um, in terms of all of the options that we have for treatment of metastatic hormone sensitive or APMS or N disease by thinking about Otis. So he's a 62-year-old gentleman. He has a history of hypertension that's relatively well controlled on lisinopril. He presented to his physician with some bothersome lower urinary tract symptoms, things like urgency and going more frequently, particularly with nocturia. His PSA was checked and it was 125, and so he was sent over to the urologist, underwent imaging and a biopsy that showed grade group 5 high risk disease. And in order to complete the staging, he underwent a CT scan that showed extensive bony metastatic disease, no visceral involvement in multiple pelvic and retroperitoneal lymph nodes. So we need to think about whether we give this individual, Otis, ADT and ARPI doublet therapy. Do we want to do that? Perhaps do we do that for 6 months, see if he gets to that ultra low PSA and then add on chemotherapy? Do we choose to add chemotherapy up front? Do we want to think about and talk with the patient about the different adverse events that can happen and how we work through those and support him, and what are his preferences when it comes to all of this? And certainly we have to think about quality of life. So, Matt, I wonder from your perspective, what do you focus on in these conversations and what might you choose for this individual, Otis?
Yeah, so, first of all, make a brief comment that we don't have a lot of the biomarker data that we'll be touching upon. But just using this, case, I think I look at 2 broad categories of information. One are the tumor-related features, and the other one is patient-related factors. So here we have a patient with de novo, high volume metastatic prostate cancer, and a triplet would be appropriate. And specifically talking about ADT, RP, and docetaxel. Technically, we don't have a clinical trial that has compared a triplet to a doublet that is ADT and RP. All of our clinical trials that have tested a docetaxel containing a triplet with an ARPI have had as a control arm a chemotherapy. So it is in principle, not unreasonable to consider an ADT ARPI a doublet. But I think in this particular patient, given the relatively modest comorbidity profile, that I would probably encourage the patient to get a triplet so long as there were no specific factors that would lead me or the patient to move away from a docetaxel. For example, if the patient had a peripheral neuropathy, he had a personal um, experience with chemotherapy in a family member, he was afraid to get chemotherapy, a lot of different factors that the patient may have in his profile that might sway us away against a docetaxel. In the VA, patients can sometimes live quite far away from the major VA medical center that is delivering docetaxel. That's another factor that could be considered in a logistical analysis of how to treat the patient.
I completely agree, and, I would add sometimes people are caregivers for others, and so that can also make it difficult, or they don't necessarily have supports in case they run into trouble with chemotherapy. So all these things are so important, and particularly in a veterans population, where people may be more or less connected to different, social sort of community engagement. If people have high engagement, it can be easier sometimes to trust that they'll be okay on chemotherapy because somebody can be there to help take care of them. But if they're more isolated, they live far away from people, that can be hard, or if they are a caregiver for others. So definitely things for us to think about. And then also just to reiterate your comments about biomarker testing, I think we'll talk about that in a few minutes. The decision and discussion that we're having here on this particular patient is for treatments that are available right now today for us to make a decision with patients. And although there are some newly approved therapies that we absolutely will consider using, sometimes it takes a few weeks or even longer, depending on if we have access to pathology and if we can get germline and somatic genetic testing for us to know whether the patient has the biomarker to be able to get those treatments. So I think those are all great comments. So, would love to hear from you. What would you do? What treatment regimen would you recommend for this patient, Otis? He is a 62-year-old gentleman. He has high volume metastatic APMN or APMS, and he has metastatic hormone sensitive prostate cancer in our old terminology. Would we do ADT monotherapy and PSA monitoring, ADT and an ARPI doublet, ADT and an ARPI and docetaxel triplet, ADT and docetaxel? We're not sure. Please let us know. And our correct answers are here. I think the most appropriate answers for this individual without incorporating biomarker testing would be ADT and ARPI or ADT, ARPI, and just Taxol, just as we talked about, and get that biomarker testing. One thing just to comment here, and would love to hear your thoughts, ADT and docetaxel is really actually not on the guidelines anymore, Matt. Is that something you would think about, or has that gone by the wayside now that we have triplet regimens?
I think the latter. I think it's largely gone by the wayside. When we use a doublet, we're using ADT and an RP.
And at the VA, luckily, these are medications that are covered. These can be very difficult for people to get when they have to use their pharmacy benefit outside of VA if they're in a private pharmacy. But the VA does provide these agents, and I think it can be a real benefit for veterans to get that. Has that been your experience, Matt?
Oh, for sure. As I mentioned earlier, I have patients at my academic affiliate that I've brought over to the VA for issues related to cost. The most a veteran can pay for a month's supply of any drug is $11. And at least at our VA, we do have a lot of the most advanced imaging modalities, and I don't have to worry about trying to get insurance authorization. In many ways, managing my patients at the VA is a lot simpler for me than at my academic affiliate.
Absolutely. And I don't work in a VA. I actually trained in a VA. My clinic, my follow-up clinic for patients when I was in medicine resident was in the VA. And I had patients who did their continuity, or my continuity clinic was there, but they would come for medications and just to check in every once in a while. And I now send patients who have the VA benefit to get a lot of their medications there. And it's great care. And a lot of times I encourage them, you also have a great doctor. Stick with them, come back to me if you need me, but you're getting great care. So the VA has been a wonderful resource, I think, for our patients. So moving on, I think we've alluded to this and mentioned it outright that we are increasingly using biomarkers to make decisions, to personalize our care for our patients, and try to match the treatment with the biology of the cancer. So the Capitella 281 trial is relatively recently reported and has actually led to a new approval for our patients with APMN and or S in patients who have P10 deficiency. So I'll talk a little bit more on the next slide about how we define that. Patients had metastatic, newly diagnosed de novo metastatic hormone sensitive disease, and they were enrolled and randomized to receive ADT and abiraterone or ADT, abiraterone, and capivasertib, which is an AKT inhibitor. Patients were monitored for a primary endpoint of radiographic progression-free survival with secondary endpoints, including overall survival, quality of life, skeletal events, and other typical endpoints. And then there was a post hoc analysis that looked at these outcomes in terms of disease control by the degree of P10 that was lost. When we look at that comparison, we can see that there's an improvement in 7.5 months in terms of radiographic progression-free survival when we add capivasertib to abiraterone versus ADT and abiraterone alone. And really importantly, we are comparing to a very, very strong control arm. This is a standard of care, ADT and abiraterone, very strong standard of care arm that is hard to overcome, particularly in a disease group of patients who have a more aggressive disease, a poorer prognosis because of P10 deficiency. So this led to the approval of the combination of capivasertib with abiraterone in metastatic hormone-sensitive disease in patients who have that P10 deficiency of 90% or more just in June of this year. So how do we find this P10 deficiency? This is something that we're all trying to think about and work into our workflows. This is done by IHC staining, not something that we've done before in metastatic prostate cancer routinely. Certainly, we do IHC staining for things like PSA, and we're looking for different things on our stains, but P10 deficiency is going to be new for us. And it's something that we've had to work into our own pathology lab at our center recently as well. So what we can see here is that you can see that there is a visible difference on that slide on the right-hand side when patients have a loss of P10 versus intact P10. And thankfully, our pathologists are very used to looking at all of this. Well, we also have to test for HRR deficiency, and that is because there are studies, including the Amplitude trial, which is listed at the top of this slide, and the TelePro-3 study, which is listed at the bottom of this slide, which show us that if we add either niraparib in the top of this slide to abiraterone or talazoparib in the bottom schema with enzalutamide for patients who have either a BRCA2 mutation in the top or with several different HRR mutations, we can do better in these patients when we compare it with the control arm of either ADT and abiraterone in the Amplitude trial or ADT and enzalutamide in the TelePro-3 trial. So we know we already have an approval for patients with BRCA2 deficiency. We can add niraparib and abiraterone as their triplet in that metastatic hormone sensitive space. And as we can see here, the hazard ratio there is 0.52 for those patients with a deficiency in BRCA2, and that is an approved regimen. TelePro-3 was actually studied in patients with a number of HRR mutations. We do not yet know the status in terms of the FDA approval, but that is under review right now. We can see that our PFS was improved with that hazard ratio of 0.481, so highly statistically significant across those HRR alterations. So I think it's really important and exciting that we are also moving radioligand therapy earlier. So the PSMA addition trial is listed at the top of this slide. This is for patients with metastatic hormone sensitive prostate cancer who have PSMA PET positive disease. And patients came in and were randomized to treatment with ADT and an ARPI with or without lutetium 177 PSMA 617. But the primary endpoint here of radiographic progression free survival. And the PSMA addition trial was positive, and we're going to talk about the results in just a moment. At the bottom of the slide, we can see actually quite an exciting trial. This is a study for patients who have recurrent prostate cancer that is PSMA PET positive. So this is traditionally what would be considered a biochemically recurrent population, but when we get a PSMA PET, there we can see some areas that may be amenable to metastasis-directed therapy. So in this trial, all patients will get metastasis-directed therapy or SBRT to those visualizable lesions, and then we'll also get half of them will be randomized to get lutetium 177 PSMA 617. The most important part of this trial, in addition to having access, of course, to radioligand therapy in this earlier biochemical recurrent setting, is that this is a non-castrating option for patients. So there is no androgen deprivation therapy included in this study, which I think is highly attractive to patients. And it will be very interesting to see how this may move the needle for patients and allow them to delay the time to receiving that castrating therapy. The primary endpoint here is metastasis-free survival, and I believe this study is still enrolling. So let's move on with the PSMA addition. Of course, this is the phase 3 registration trial that was studying standard of care ADT and ARPI with or without lutetium PSMA 617. So patients came into this study with newly diagnosed metastatic hormone sensitive or APMN or S disease. They all started on ADT and ARPI of the physician's choice. That's very important. It could have been any of the ARPIs. And they were randomized to receive lutetium PSMA 617 or to continue only with their ADT and ARPI. The primary endpoint here was radiographic progression-free survival. And what we can see is that the hazard ratio there demonstrates an improvement in rPFS, favoring the addition of lutetium PSMA 617 to that ADT ARPI backbone versus ADT and ARPI alone. Hazard ratio 0.72, highly statistically significant. There was also a very clear positive trend towards improving overall survival in that initial data output, with a hazard ratio of 0.83, did not quite meet statistical significance. Additionally, there was no new safety signal here and no clinically significant difference between the two treatment arms in terms of decline or change in health related quality of life. So we achieved that benefit without compromising too much as we add on another therapy. Also critically important and so exciting, at the end of July of this year, so just shortly ago, lutetium PSMA 617 was approved in this frontline metastatic APM-N or S setting in combination with ADT and ARPI. And it's for all adults with PSMA PET positive metastatic APM-N or S prostate cancer, again, previously referred to as metastatic hormone sensitive prostate cancer. Also, really exciting in that FDA approval, there was a report of a subsequent updated analysis that lutetium PSMA 617 combination with ADT and ARPI further reduced the risk of progression or death by 33%. So the hazard ratio updated here 0.67 with a positive OS trend, again, favoring the addition of lutetium PSMA 617 to the ADT and ARPI background. Hazard ratio for OS 0.80. So solidly, even a little bit lower, 95% confidence interval, just crossing one at one, the upper bound at 1.01. So data are continuing to mature in terms of that overall survival analysis, but solidly with a trend there towards improvement. So quite exciting with this new addition to the armamentarium for APM N or S. And we can see that we're also achieving some nice PSA responses over here on the right. So there are so many treatments that are moving into that metastatic hormone sensitive or APM-N or S space. These were often established in our metastatic CRPC or APMR space. So we have a lot of experience with them there. Dr. Rettig, can you walk us through that data?
Great overview for the APMN or S state. And now we'll take a dive into the APMR, formerly known as MCRPC space. So we now have a number of approved treatments based upon biomarkers in this space. We have PARP inhibitors in patients with BRCA alterations, as well as other HR alterations. And now we also have PSMA radioligand therapy in PSMA positive patients, both in the pre and post taxane setting. And some of these questions at the bottom are particularly germane to our veteran population, certain barriers that veterans can face to get the appropriate testing, biomarker testing in the first place, and how we can overcome these barriers, including factors related to the patient's medical profile, quality of life, and other preferences a patient may have. And we can touch upon some more of this in a bit. So, PARP inhibitors have been approved for APMR, both as monotherapies as well as combination therapies in combination with an ARPI for first line MCRPC or APMR. So let's turn our attention to PSMA radioligand therapy. And this is a schematic of how it works. Basically, there is a ligand that binds to PSMA, a plasma membrane protein, and that ligand is conjugated to lutetium 177, a beta emitting radioisotope. So, beta particles are electrons that have a relatively low energy transfer, but they travel a fairly long distance, and they tend to cause a single strand DNA damage initially, although some double strand DNA damage can occur. So the first study was a really key study known as the Vision study, and this was a comparison of PSMA 617 radioligand therapy with standard of care versus standard of care only in the post taxane setting. And you can see that both overall survival was improved, shown on the left, as well as radiographic progression free survival. And this led to the FDA approval of PSMA 617 in the APMR post taxane setting. So, in addition to the hard endpoints of overall survival and radiographic progression free survival, PSMA 617 also is improving the quality of life of patients. So it just adds strength to the notion that PSMA 617 is efficacious for APMR post-taxane patients. So this is an analogous study of PSMA 617 performed in the pre-taxane or taxane naive setting. And this was a comparison of PSMA 617 versus an ARPI switch. So, a patient had abiraterone, they got enzalutamide, or vice versa. The primary endpoint was RPFS, and that was clearly met, and that's shown on the left with a hazard ratio of 0.49, so a 51% reduction in the risk of radiographic progression or death. And there was also a prolongation in the time to worsening of patient-reported outcomes. In other words, another way of saying patients had better quality of life with PSMA 617, and the FDA approved PSMA 617 in the pre-taxane APMR setting in March of 2025. So now we have PSMA 617 in the post-ARPI setting, both pre and post-taxane. So here are some of the key adverse events associated with PSMA radioligand therapy. So PSMA is, of course, expressed on tumor cells, but it's also expressed on normal tissues, including the GI tract, the liver, the spleen, and importantly, the salivary glands. There's also some expression in the proximal tubule of the kidneys, and the radioisotope, the radioligand is excreted by the kidneys. So some of the adverse effects that you see here are related to the physiologic or normal expression of PSMA. The most common adverse effect is dry mouth. Tends to be mild and often reversible, but you can also see GI toxicity and just generalized fatigue. There's a minority of patients who can have a transient pain flare, and I do let patients know about that because you can imagine it could be quite upsetting to a patient if you get a treatment for their cancer and their pain gets worse. Um, and there's also the potential for myelosuppression. So monitoring CBC at baseline and prior to each dose is really critical. There are also some precautions that patients have to take in terms of exposure uh, to others who may be near them. This is particularly important for women of childbearing age, especially if they're pregnant and children, and usually the nuclear medicine or occasionally the radiation oncologist who delivers the therapy will give the patient a information sheet that lists some of these precautions that should be taken to minimize radioactivity to others. So we have another question here. It's which safety counseling is most appropriate to discuss with a patient before their first lutetium PSMA radioligand therapy infusion? One, no home radiation precautions. Discuss management of hot flashes and blood pressure. Two, radiation precautions, CBC, cytopenia warnings, renal risk and hydration labs. Dry mouth expected but low grade. Three, hold fluids for 48 hours. No routine CBCs required. Or four, I'm not sure. Well, I think the answer is pretty obvious based on what we talked about. There are radiation precautions. There is cytopenias that can occur as well as nephrotoxicity. So it's important to remain hydrated. Importantly, nephrotoxicity can be quite late, even a year or so after the completion of a course of PSMA radioligand therapy. And dry mouth is also fairly common, again, low grade, and patients should be aware of it. I often tell patients to get some sucking candies, lemon drops, but we do have treatments if necessary for more high grade um, xerostomia. So here's a dive into the Alsimca study, the phase 3 study that led to the FDA approval of radium 223 in the MCRPC or APMR setting. These were patients who had symptomatic bone metastasis, had to have at least two bone mets, no visceral disease. If they had lymph nodes, they had to be less than 3 centimeters. Of course, as a calcium mimetic, radium 223 will really only target bone disease, and that's why a limited lymph node involvement was required for this study, and certainly no visceral involvement. The patients could have been pre and post taxane, and they were randomized to a best supportive care with or without radium 223. And you can see that the overall survival is improved with radium 223. That's about a 3 month absolute improvement in the hazard ratio of 0.7. And that's frankly in line with most of our monotherapies that have been approved in the APMR setting, where we see median overall survival improvements of around 2.5 to 4.5 to 5 months. So, what about adding radium 223 to an ARPI? Does that improve outcomes? So, this was addressed in the Piece 3 study. The vast majority of patients had no ARPI exposure, only 2.5% did. And the patients were randomized to enzalutamide only or enza plus radium 223, primary endpoint of RPFS, and the key secondary endpoints shown there, including overall survival. So, first of all, it's really important to include a bone protecting agent when using this combination. And what you can see is that patients who didn't get a bone protecting agent, especially when they got the combination, had a much higher incidence of skeletal related events, specifically fractures. So whenever a combination of radium and enzalutamide is being considered, it's critical to have a bone protecting agent on board. So here are the data from this Piece 3 study. So the combination of radium and enza improves RPFS, as shown on the left, has a ratio of 0.69, as well as OS, as shown on the right. So the combination is better at improving RPFS and OS as compared to enza only. So here is a small set of studies, phase 1 and phase 2, of a combination of radium 223 and PARP inhibitors, and the results show essentially that the RPFS is superior with the combination as compared to radium only. This is not a definitive phase 3 study, but certainly intriguing. So here are some data of on veterans who received radium 223. The VA has been using radium for at least a decade. There have been hundreds of patients treated. They tend to be a bit older, and as is known for our veteran population, about a quarter are African American. Just by way of context, about 12 to 13% of the U.S. population is African American. About 19% of veterans are African American, and about 25% of African American prostate cancer patients in the VA are African American. So median survival was 11.2 months, consistent with real world data for the use of radium 223. And older age remains an important prognostic factor, as it does for many different therapies. And on the right, you can just see that most patients got the planned 6 cycles of radium 223. These are other investigational radiopharmaceuticals that are in the clinic for APMR. Some of these are PSMA alpha particle based. They use perhaps different ligands. There are combinations that are shown, for example, docetaxel and radium versus docetaxel. This is the DOOR study. That's a phase 3 study. We actually, interestingly, have a randomized phase 2 study that's an investigator initiated clinical trial where patients with APMR, irrespective of the number of prior treatments, come off of all hormone therapy. And as long as they have 10 or fewer METs on molecular imaging, PSMA scan or FDG scan, they receive comprehensive radiation therapy in the form of SBRT to all of the METs, which is sandwiched in between 2 doses of PSMA 617. I can tell you that the study is over half enrolled, and we have far exceeded the futility analysis, and many patients are doing quite well, including in the randomized in one of the arms in the randomization, patients who actually get testosterone replacement therapy, because these patients have typically been on ADT for a long time and don't recover their gonadal function for often years. And those patients are doing quite well. So let's turn to another case. This is Nelson now. He's older than our prior case of 62 years old. Nelson's 78 years old. He's a Vietnam veteran. He's receiving care at the VA, but does use community care, importantly due to travel distance. He lives 110 miles from the VA, and he's the primary caregiver for his wife, which is an important social factor that Dr. Morgan's mentioned earlier. He really has a strong preference to avoid prolonged inpatient stays and, quote, harsh chemo, unquote, due to prior family experience. His comorbidities include type 2 diabetes, complicated by a peripheral neuropathy, CKD, coronary heart disease, PTSD, insomnia, and chronic anemia. In terms of his prior therapy for his prostate cancer in 2018, he had high risk prostate cancer and got radiation and ADT. He had biochemical recurrence in 2021, got an ARPI and ADT. And then in 2023, bone and pelvic nodes, nodal metastases developed, and he switched ARPIs. And in 2025, his PSA is rising and he has radiographic progression. So currently, he feels tired. He's got a bone pain in his spine and hip. His PSA is rising, as you can see, and his PSMA PET scan shows multiple PSMA avid bone mets, all of which, importantly, are above the SUV max, the uptake by the liver, which is an important a predictor of response to PSMA radioligand therapy. So, question: is the patient an appropriate PSMA 617 candidate? What are the issues with terms of timing, frequency, support systems needed? And what are our thoughts on chemo therapy? So let me ask Dr. Morgans what her thoughts are about PSMA 617 and issues that might surround this particular patient.
Yeah, so I think that that treatment option meets a lot of the criteria that this patient is interested in doing. This does allow the individual, the patient to have an option beyond chemo. I think that's great and is requested by many folks. And for many people, the quality of life experienced on these radioligand therapies is um, a little bit better than what we would expect on chemotherapy, if not a lot better. There's some fatigue associated with treatment. Counts can go down. Obviously, there are the radiation safety parameters, but many patients tolerate it quite well. The concerns I would have for this particular patient are that he does live a fair way away and does need to have rides to clinic, and so this may be a little bit burdensome. But this treatment, if he gets RLT therapy with lutetium 177 PSMA 617, is only given once every 6 weeks. So perhaps this is less burdensome than needed. Only other things I would mention here, just from a safety perspective, this patient does have chronic kidney disease and also has chronic anemia. So we'd have to make sure that the GFR was at a place, and it seems to be where it's safe to give this agent. And we would want to monitor counts, certainly in between visits. 6 weeks is too long to go between checking, because we can get some cytopenias, some patients affected more than others in terms of that anemia getting worse. What do you think, Matt?
Yeah, I totally agree with everything that you've said. I would also add that the patient is the wife's primary caregiver. But in terms of the radiation exposure, it does not prevent the PSMA radioligand therapy usage doesn't prevent the patient from remaining as the primary caregiver. One of the main precautions is that the patient can't sleep within 3 feet of someone else for 72 hours, and very often that's something that's feasible for patients to adhere to. So, in terms of using radioligand therapy, there are some important considerations, especially in the VA. Most VAs actually don't have the current ability to deliver it. Um, and that may require either a referral to a VA that does or a referral to the community. And of course, all veterans have the option of being referred to the community for their care, and the VA will cover the costs of community care. Um, you as part of the delivery, we need radiation or nuclear medicine expertise and specialists that can deliver it, and that involves compliance with radiation guidelines and appropriate disposal of nuclear waste.
So, to follow up, this patient has had 2 cycles, and after that point, patient's actually having better control of hip pain. PSA has come down, but just as we talked about, the labs show that the platelets are being affected with a grade 2 lowering of the platelets to 72,000. There's a grade 2 anemia with a hemoglobin of 8.9, and ANC is 1.4. As we think about that, as we think about monitoring, how do you manage cytopenias and monitor cytopenias and blood counts for a veteran who lives far away and it may be hard to come back to the primary clinic to get those checks?
There are also outpatient clinics where the patient can go. These clinics are often located much closer to where the veteran may live, and they can get their blood drawn without having to come all the way back to a major VA medical center. So, really, I think PSMA radioligand therapy is about communication and multidisciplinary care. And the more we interact with our colleagues and our social workers and other support staff, the better we can deliver care and optimize the quality of life for our patients. So, I just want to spend some time about the importance of clinical trials. And when I have a patient at the VA, I start talking to them about the possibility of clinical trials even before they may need a clinical trial. So it sort of sets the stage, and you develop a relationship with the patient. And as the patient may progress and needs a clinical trial, you're not throwing something completely new at them. So I think that's really important. And we know that patients who join clinical trials tend to do better than those that don't. And there's a lot of advantages to research at the VA. There's the diversity of the patient population. It's one integrated healthcare system with one electronic medical record system, which is the oldest in the country. And we have a lot of resources, including NAVREF, that can interact with our commercial partners to help execute clinical trials and identify VA sites that are interested in clinical trials in any disease category, be it cancer or prostate cancer or other cancers. So, as we've seen, there's really a lot of exciting advances for our patients with prostate cancer. I want to thank Dr. Morgans in particular for joining me today and giving us that great overview of what we're now calling APMR, APMS, and APMN.
Wonderful. Well, thank you so much. It's been my pleasure. And we hope that all of you found this workshop useful and informative for your practice. Please do remember to submit your post test and evaluation for credit and download the slides and practice aids. And we just really appreciate you joining and your interest in prostate cancer and also in veterans care. Thank you.
Thank you.